recording. All right, patient assessment. So we're gonna look at something that's a little more familiar. Patient assessment. Introduction. Patient assessment. The patient assessment process has 5 steps. Scene size up, primary assessment, history taking, secondary assessment, and reassessment. The order in which the steps are performed depends on the patient condition. Every patient gets a primary assessment. What is going to be different as an advanced EMT is when you perform your basic airway, breathing, and circulation assessment and management. If your basic interventions are not successful, then you will perform your advanced airway assessment, breathing assessment, and circulation assessment. The primary assessment is going to be the area of the assessment where you make contact with the patient. This is where you're going to identify live threats and address these live threats appropriately. A sign is an objective condition you observe. So it's going to be based on your observation. So it is what you can see, what you can hear, what you can smell, and what can be measured. A symptom is a subjective condition. This is what the patient complains about, or this is what the patient tells you. The chief complaint is going to be the reason why EMS is activated or called. Critical decision making and critical thinking. So as an advanced EMT, you have to develop critical thinking skills. In order to be able to have strong critical thinking skills, you must be able to gather information, you must be able to evaluate that information, you must be able to synthesize the information, break it down systematically or technically, and then develop an idea of the patient's problem and formulate a field impression. Now, strong critical thinking skills is based largely upon your understanding of anatomy and physiology, pathophysiology, assessment, and the application of skills. So there must be a solid foundation in anatomy and physiology. You must be familiar with all the systems in the body and how these systems function. You must be familiar with abnormal function of these systems, which is the pathophysiology. You must have strong assessment skills, a consistent method of assessment, and you must know when the equipment or skills must be applied based on the patient presentation, and it must be done properly. With a focus on these areas over time, as you gain experience, once you're consistent, your critical thinking skills will develop and you'll be able to make critical decisions. Now, the first area of the patient assessment algorithm is the scene size up. This is where we gather information, right? So this is the information gathering stage. We continually assess the scene. So we must maintain situational awareness. We consider a variety of factors, combine information from dispatch with your observation of the scene. Once we arrive on a scene, we have to think about safety. So ensure scene safety, consider traffic safety, look for other hazards, protect patient and bystanders. And once there is something present on location that would deem the scene unsafe for you to respond and provide appropriate treatment for the patient, then you need to request that resource, whether it's fire, whether it's police, whether it's special rescue, hazmat team, you request that resource or resources. Once we have ensured that the scene is safe, we will then determine the mechanism of injury or nature of illness. The MOI is specific to your trauma patient. The nature of illness is specific to the medical patient. The mechanism of injury is how the patient became injured. Traumatic injuries are the result of physical forces applied to the body. So when physical forces are applied to the body, if the body is not able to dissipate that force, then it results in injury, soft tissue injury. Common types of trauma. Blunt trauma occurs over a broad area and the skin is not broken. So the damage is going to be internal. Penetrating trauma occurs at specific points of the contact between the skin and the object. So there is now an opening, so a high risk for infection exists, but primarily your concern is going to be bleeding control. When we talk about the nature of illness, it's specific to or medical patients. So it's whatever the patient is complaining of or whatever the patient is presenting with. Example, seizure, heart attack, diabetic condition, poisoning. Best describe the patient's chief complaint and medical history. Talk with the patient, family, or bystanders. So when you start to consider the nature of illness, you can get that information directly from the patient, you can get it from family members, or you can get it from bystanders. If the patient is not able to communicate effectively with you, or the family members or bystanders can't give you valuable information or information that you can rely on, then you need to ensure that you check the patient's pupil reaction, their pulse oximetry, blood sugar, and end-tidal CO2 level. So you need to get them on a end-tidal CO2, whether it's capnography or colorimetric, preferably capnography. So you want to look at their CO2 levels. In our scene size up, we will take standard precautions. So these are protective measures recommended in dealing with potential exposure risks. Assume all patients pose a risk of infection. Consider and adapt standard precautions and personal protective equipment to the task. So if you're dealing with the upper airway or performing airway management, nose, mouth, eyes need to be protected. Dealing with a lot of blood, you need to ensure you have on your gloves and your gown. You have a patient that you consider to be sick with a contagious, possibly contagious virus, then you need to ensure that you wear the proper protective suit, that is based on your protocols for that kind of situation. In the scene size up, we will determine the number of patients. It is critical in determining the need for additional resources. So if there's multiple patients that exceeds your available resources, then a mass casualty plan need to be implemented. Consider additional or specialized resources. And this can be paramedic backup, it can be your medical support, it can be the fire department, it can be law enforcement personnel. Now, once we have completed the scene size up, the next phase of your assessment is a primary survey or primary assessment, the same thing. The purpose of the primary survey is to identify and initiate treatment of immediate or imminent life threats. Vital signs are used to evaluate the patient's condition. Always give priority to life threats. It's not an in-depth physical exam. So within the primary, you're looking at the patient's level of consciousness, airway, breathing, circulation. Now, within the primary survey, we will form a general impression. So note the patient's appearance, position that you find them in. Are they exhibiting any life-threatening injuries or conditions? If there is an injury present, what caused it? Does the patient seem to be able to communicate with you effectively? Can they answer your questions when you ask them? Maintain a high index of suspicion and begin treatment. Assess the airway. Be alert for signs of airway obstruction. Determine if the airway is open and adequate. Responsive patient, a responsive patient who cannot speak or cry most likely has a severe airway obstruction. For unresponsive patients, you should consider unresponsive patients should be considered to have experienced a traumatic event. And if your patient is unresponsive, you definitely need to be thinking about management of the airway. For your unresponsive patient, if you suspect trauma, you will use a jaw thrust maneuver to open the airway if that's required. The jaw thrust will manipulate the mandible without causing shifting of the neck, moving the tongue out of the airway. When a patient, an unresponsive patient, airway is compromised, it can be as a result of the tongue, it can be dentures, blood clots, vomitus, mucus, food, and foreign objects that cause the obstruction. If it's the tongue, using manual procedures can get the tongue out of the airway. If it's the dentures, manual procedures can get it out. If it's fluid, then suction may be required, and we try not to suction the patient's airway in a neutral position. So once it's possible, we will turn the head to the side or return the patient as a unit. If it's a foreign object, we follow the BLS protocol or guidelines for a patient with an object in the mouth. Now, once we have positioned a patient's airway, the next phase of the assessment is to determine if the patient is breathing adequately. So does the patient appear to be choking? Is the respiratory rate too fast or too slow? Are the patient's respiration shallow or deep? Is the patient cyanotic? Do we hear abnormal breath sounds when listening to the lungs? Is the patient moving air into or out of the lungs? When we assess breathing, we will look at the rate, the rhythm, the quality, and depth of the patient's breathing. The rate is how fast or slow the patient is breathing per minute. The rhythm is the consistency of the chest rise. The quality is whether or not you can hear abnormal sounds, whether or not the patient is using muscles, and the position that the patient is in. Depth is whether or not you can see visible chest rise bilaterally. These are the things you will assess when assessing breathing. Cannot be one thing that you assess, it must be a combination. So if you have not assessed rate, rhythm, quality, and depth of your patient's breathing pattern, you have not done a proper breathing assessment. Each complete breath includes inspiration and expiration. With inspiration, there is negative pressure. With expiration, there is positive pressure. Rapidly assess respirations to determine if the rate is normal, fast or slow, the depth is normal or shallow, chest rise is equal or unequal. So rate, rhythm, quality, and depth. Assess the patient's breathing and listen to breath sounds. So once it's necessary, listen to the patient's breath sounds and listen anterior and posterior. Observe how much effort is required for the patient to breathe, shallow or deep. Labored breathing is characterized by the patient's position, concentration on breathing, and increased effort and depth of each breath. Two common postures that you need to look out for is the tripod position and the sniffing position. You will see the sniffing position more in the pediatric population. Tripod is going to be your older patients. Once we have assessed airway breathing, next is circulation. So we want to assess the pulse. Pulse pressure is a pressure wave. Pulse is a pressure wave that occurs as each ventricular contraction causes a surge in blood circulating through the arteries. Most easily felt where a major artery lies near the surface. Assess pulse to determine if it is present or absent, normal or fast, normal, fast or slow, weak, thready, or strong and bounding. So with the pulse, you're going to check the rate, the rhythm, and strength of the pulse. If the patient is communicating, peripheral. If the patient is not, central. And for the pulse, you can use 15 seconds to obtain the pulse rate. That is acceptable now. In children younger than 1 year, you will use the brachial pulse. If you cannot palpate a pulse in an unresponsive patient, begin CPR. However, just note that for your infant and newborns or neonate, we do not wait for them to become fully pulseless before we start CPR. Once your pulse is below 60, we start CPR. If the patient has a pulse but is not breathing, provide ventilations. Assess skin. So skin is a part of your circulation assessment as well. Perfusion is assessed by evaluating the patient's skin color, temperature, moisture, and capillary refill. Capillary refill specifically for your pediatric population. Skin color determined by blood circulating through vessels and amount and type of pigment in the skin. conjunctiva, delicate membrane lining the eyelids. So you can look at the palms, you can look at the mucous membrane in the mouth, you can look at the lips, you can look at the inner eyelids or the lining of the eyelids. You always check peripherally for color changes, and if present, then check for it centrally. If it's central, if the change is central, then the brain is being affected. Inadequate peripheral circulation will change the appearance of the skin. Cyanosis, skin appears blue or gray. Liver disease or dysfunction may cause jaundice. In circulation, we will consider the patient's skin temperature. Abnormal skin temperatures are hot, cool, cold, and clammy. Cool, pale, clammy skin, these are indicators for shock or hypoperfusion. Skin moisture, skin that is wet or moist from sweat or excessively dry and hot suggests a problem. When skin is bathed in sweat, the skin is described as wet or diaphoretic. For the capillary refill time or CRT, you're squeezing the blood out of the capillaries and they should take less than 2 seconds to return. It's a very useful assessment for your pediatric population. Provides an indication of pediatric patients' level of perfusion. Place your thumb on the fingernail, gently compress. So you're squeezing the blood out of the capillaries. It should return in less than 2 seconds. Assess circulation. Assess and control external bleeding. So once we note any signs of external bleeding and it is considered to be major, we have to control it. Identify and immediately control any major external bleeding. You will use direct pressure with your glove hand, followed by sterile dressings and bandages over the wound, and this will control the wound in most cases. Restoring circulation. Take immediate action to restore or improve circulation. So apart from using your basic methods to control blood loss, if that's not effective, or depending on the amount of blood loss that has occurred, you will have to consider starting IV access for the purpose of fluid resuscitation. If there is no pulse, begin CPR. Now this is new. So as an AEMT, your assessment is airway, breathing, circulation, disability, exposure. Airway, breathing, circulation, disability, exposure. For X, sometimes you'll see X, A, B, C, D. X is exsanguinating hemorrhaging. It represents that. Now, don't freak out. It's not anything new. It's something that you have always been doing. So after you complete your ABCs, you should know at this point the patient's level of consciousness, and you should know their GCS. Right? So after ABCs, you should know what a patient's level of consciousness is, and you should know their GCS. And that's really what disability is looking at. So assess the patient for disability. Perform a brief neurologic evaluation. Ascertain gross LOC. So if you didn't spend a lot of time on it initially, now you're going to be more specific with your LOC assessment, right? Is the patient still unresponsive? Does the patient respond but is confused? Does the patient respond but they are fully oriented? Determine the patient's normal mental status. If a patient is found to be confused or disoriented, you need to find out if this is the norm, and if it's not the norm, when was the last time the patient was seen behaving normal? Indicators for spinal immobilization or spinal motion restriction include trauma with MOI that indicates potential for spinal injury, pain or tenderness in the neck or spine, paralysis or neurologic complaint, priapism, altered mental status, difficulty or inability to communicate. And further into the course, I will go into more details as it relates to spinal motion restriction. AVPU scale tests the patient's responsiveness. Awake and alert, responsive to verbal stimuli, responsive to pain, unresponsive. Orientation tests a patient's mental status, checks memory and thinking ability. And the GCS assigns point values for eye-opening verbal response and motor response. So when you initially make contact with the patient, you'll find out the name of the patient and what's wrong with the patient. After you've completed your airway breathing and circulation, you can become more specific in your LOC assessment, specifically for orientation and your GCS. And that would be considered assessing for disability. Points that you can assess for pain: pinching the earlobe, pressure on the supraorbital nerve, pinching the neck. Now, once you've completed your airway breathing, circulation, and disability, next phase is rapid scan. Perform a rapid full body scan. So after your ABCs and you know what your patient's LOC is, and you know their GCS, you should know at this point if you need to do a rapid scan or you need to do a focus assessment on the patient. So expose the patient, then cover. So we will expose them to look for stuff, but once we finish, we're going to cover them back up. Visually inspect each area to ensure an accurate and thorough assessment. Perform a rapid full body scan. It helps to identify other injuries, and we will utilize inspection, palpation, and auscultation, and we are using our DCAP PTLS at this point. Identify and treat life threats. Only a few conditions cause sudden death: airway obstruction, respiratory arrest or failure, cardiac arrest, shock, severe bleeding. Recognize and take immediate steps to correct them. Begin with assessment of the ABCDEs. Controlling life-threatening bleeding takes priority over airway and breathing concerns. Now, after we've completed our ABCDEs, we should know what is the priority in terms of patient care and transport. So determine the priority of patient care and transport. Rapid full body scan will assist you in determining transport priority. High priority patients should be transported immediately. Protecting the patient's spine and identifying fractured extremities are integral parts of packaging for transport. Spend minimum time on scene with patients who have sustained significant trauma. Rapid transport is one of the keys to survival for a critical trauma patient. Remember your golden period or your golden hour and your platinum 10. And for your trauma patient, within 6 minutes, we need to address life threats. We need to be ready to move with that patient. After we have completed our primary survey, then the next phase is going to be history taking. Provide details about the patient's chief complaint and an account of signs and symptoms. Signs will be objective information, symptoms will be subjective information. Gather as much history as possible unseen from family, friends, bystanders, and medical identification tags. If you cannot get information from the patient, family, friends, bystanders, or tags on the patient, then you look at the patient for clues and you ensure that you check the pupils, pulse oximetry, GMR, end-tidal CO2. And when time allows, make sure you get them on your cardiac monitor and you do a 12-lead ECG. Document all the information you have gathered. Investigate the chief complaint. Ask few simple and open-minded questions. Use eye contact, body position, and language to encourage the patient. Do not interrupt and be empathetic of the situation. Investigate the history of the presenting illness. And when you're going to investigate the history of the presenting illness, you're using your OPQRST. So the OPQRST investigate the illness, the history. It provides history of the presenting problem. It doesn't necessarily have to be specific to medical, can be applied to a trauma patient as well. O is for onset, so this is when the problem began, what patient was doing at the time of the incident. That's onset. Provocation or palliation, provoking factors, anything that brings on the problem, palliating factors, anything that brings relief. Quality, patient's description of pain, location of pain, focal or diffuse. So the pain can be focal, it can be diffuse. Focal is specific to an area of the body. Diffuse means it spreads out. Radiating means it starts from one area of the body and move to another point on the body. R is region radiation. Radiating pain, pain that travels to another area of the body. Referred pain exists in more than one place. Severity, patient's perception of how bad the current incident is in comparison with others. Timing is the consistency. Interventions, ask about any treatment prior to EMS arrival to avoid overdosing and identify your pertinent negatives, things that you would expect the patient to complain of, but it is not present. After you have determined history of the presenting problem or injury or illness using your OPQRST, the next phase of your assessment is your sample. And that's your signs and symptoms, allergies, medication, pertinent past medical history, last oral intake, events leading up to the illness or injury. Now, special history taking situations. Alcohol and drugs. Signs and symptoms while under the influence of alcohol or drugs may be confusing, hidden, or disguised. Patients may deny abuse of alcohol or drugs. So the information that you get from these patients cannot be one can't be very reliable. You can't rely too much on the information that you're getting because they're intoxicated. Physical abuse or violence. Report all cases of suspected physical abuse or domestic violence to the appropriate authorities and make sure you involve the law enforcement or police officers. Sexual history. Some patients find sharing information regarding their sexual history uncomfortable. You may have to consider someone of the same gender, especially for female patients, asking certain questions. Consider all female patients of childbearing age who report low abdominal pain to be pregnant. We want to rule out worst case for these patients, which would be ectopic pregnancy or miscarriage. Ask about menstrual period, sexual partners, urinary symptoms, and the possibility of sexually transmitted diseases. Special challenges in obtaining patient history. Your silent patient. With your silent patients, you need to be patient. Use closed-ended questions that require a simple yes or no, and look for nonverbal clues. So watch their body language. What is it telling you? The overly talkative patient. They can be overly talkative because they have consumed too much stimulants, right? They have consumed too many stimulants. And stimulants could be due to excessive caffeine consumption, can be because they are nervous, can be because they ingested cocaine or methamphetamine, which are stimulants. Direct the patient to stick to the facts by summarizing their statements frequently. You can have patients that complain of multiple symptoms. You may have to spend extra time assessing these patients, especially a geriatric population. Cipher through their complaints and focus on what you think is most concerning to you based on the patient's presentation, and you focus on that in terms of management. Anxiety, the anxious patient. Expect anxious patients to exhibit signs of psychological shock. Be aware that emergency responses involving anxious and possibly hysterical patients can turn violent. The anger and hostility. Do not take anger and frustration personally. Remain calm, reassuring, and gentle. Always be observant. Intoxication. Information may not only be difficult to get, but also could be unreliable. You've assumed that patient's condition is the result of alcohol consumption. So there are some medical conditions that can cause altered mental status, and the patient will present as if they are intoxicated. Specifically, or an example would be a patient having a diabetic emergency. Crying. Be sympathetic and treat them with respect and dignity. Depression, or your depressed patient. Symptoms include sadness, a feeling of hopelessness, restlessness, and irritability. Patients exhibiting confusing behavior or history. Be aware of medical causes that can lead a patient to report a confusing history. Confused behavior is not a normal response. Limited cognitive abilities. Develop a habitual method for dealing with a patient who has limited cognitive abilities. Keep questions simple. Be alert for partial answers and keep asking questions. Language barrier. Consider using interpreters, translation resources, and mobile devices or mobile device apps. Use of hand gestures may be helpful for patients who are hearing impaired. Ask questions slowly and clearly. Speak slowly and face to face with the patient. Some of them can read lips. For the visually impaired patient, identify yourself, explain everything that is going to happen, stay in contact with the patient. Once we have completed the history taking phase of the assessment, The next phase is going to be your secondary assessment. The purpose is to obtain your vital signs and perform a systematic physical exam of the patient to discover things that may have been overlooked because you were too focused on your primary survey. Assess and document respiration, pulse, blood pressure, level of consciousness, skin condition, blood glucose, pulse oximetry, entitled CO2. Assess vital signs using appropriate monitoring devices. So pulse oximetry. This monitors oxygen saturation of the hemoglobin in the capillary beds. Useful assessment tool to determine the effectiveness of oxygen therapy, bronchodilator therapy, and artificial ventilation. So when you're using your pulse ox, it will guide your oxygen therapy. It will guide the use of bronchodilators when you're breathing for the patient. And if you're going to use pulse oximetry, you need to be looking at end-tidal CO2 levels as well. Pulse oximetry continued, monitor and sense. It has a monitor and sensing probe. Do not use with a patient who is showing signs of hypoperfusion or known anemia. It can give you a misleading reading. Persons who have carbon monoxide or exposure to other toxic inhalants, it can throw off the reading. If the extremity is cold, it can also throw off the reading. Non-invasive blood pressure measurement. This is done with the sphygmomanometer, blood pressure cuff. We use the methods of auscultation and palpation. I have the electronic oscillometric method. Two types of electronic devices are used in the pre-hospital setting. For us, when we're using oscillometric, it is the cardiac monitor. So the cardiac monitor can give a full set of vital signs. It has a BP cuff attachment that you can place on the arm, and you press a button, and it gives you the blood pressure reading for the patient. Do not rely heavily on your electronic devices. So if you get an abnormal blood pressure for the patient using an electronic device, then take it manually to be sure that it's abnormal. End-tidal carbon dioxide. So this is important for AEMTs and higher. The pulse oximetry measures the oxygen level of the patient. End-tidal CO2 will tell you how well your patient is ventilating. So it's a good tool to measure ventilation. So it measures carbon dioxide levels. It can be capnometry or capnography. Capnometry consists of a disposable or electronic device that measures CO2 output. And capnometry just gives you a value. That's all. It gives a value. Capnography gives a value with a waveform. Sorry about that. Hold on a sec. Right. The end-tidal CO2, partial pressure or maximal concentration of CO2 at the end of an exhale breath, measured by colorimetry, capnometry, and capnography. Colorimetry means it is a color code. It uses a color code, and you attach it to the BVM. The capnometry gives you a digital value or unit. Capnography gives you a value and a waveform. The normal range for CO2 levels is between 35 to 45 millimeters of mercury. If the CO2 level goes above 45 millimeters of mercury, it means your patient is breathing too slow. If the CO2 level drops below 35 millimeters of mercury, it means your patient is breathing too fast. And if you see a shark fin pattern, if you start to see a shark fin pattern on the cardiac monitor for your CO2 reading, it means that your patient has bronchoconstriction. And I'll go into it a little bit more down the line to actually give you an idea of what the pattern looks like on the cardiac monitor. Now, blood glucometry. Glucometer measures glucose levels in the bloodstream. Indications include known diabetes in patients with a decreased level of consciousness. So your vital signs should be done in your secondary assessment, and you can do a full body exam. I don't know why I'm saying scam. Goal, identify hidden injuries or unidentified causes. Any patient who has sustained a significant MOI, is unresponsive, or is in critical condition should receive a full body scan. Focus assessment. Generally perform on patients who have sustained non-significant MOIs, on responsive medical patients with specific complaint. Based on the chief complaint, focus attention on the immediate problem. So if the patient can tell you exactly what's happening, then you focus on that. If they can't, then you focus on the entire patient. Now, assessing the systems. Respiratory system. When we're assessing the respiratory system, look for signs of airway obstruction and trauma to the neck and chest. Expose the patient's chest and inspect for overall symmetry. Listen carefully to breath sounds, noting any abnormalities. Measure the respiratory rate, rhythm, quality, and depth. Whatever you have found, ensure that it is properly documented. Respiratory rate, a normal resting rate in adults is 12 to 20 breaths per minute. The younger the patient, the faster they will breathe. Check respirations in a responsive, alert patient without making the patient aware of what you are evaluating. Patient should not be talking when you're checking the respiratory rate. You will look at the rhythm, the consistency. So note whether the patient's respirations were regular or irregular. And if a patient has an irregular breathing pattern, eventually it's going to affect their ability to ventilate. Quality of breathing can help to identify the quality of air movement in both lungs. Can be decreased absent breath sounds on one side of the chest, and decreased movement in rise and fall indicate inadequate breathing. Can be stridor, heard if upper airway has mild obstruction caused by a foreign body or swelling. It's a high-pitched whistling type sound. Can be bubbling or gurgling. Patient probably has fluid in the passages in the upper airway. Auscultate over the upper lungs 1 inch below the clavicle. So you have the mid-clavicular line, mid-lung fields, lower lungs, and mid-axillary line. Place a stethoscope firmly against the skin. The patient is responsive. Ask them to breathe in and out. And we do not listen only to one area of the chest. So you have to listen anterior and posterior. Don't miss your lung sounds. Very important. Breath sounds, normal breath sounds. You have tracheal sounds, bronchiovesicular sounds, vesicular sounds. Not gonna focus too much on you knowing what these sounds represent. What is important is get accustomed to listening to long sounds and know what normal sounds like, and know what your abnormal sounds are. So wheezing, bronchoconstriction, your crackles, that's your fluid. Rhonchi is fluid, but it's thick fluid from infection. Stridor is upper airway, pleural friction rub. You can hear that in patients with cancer or pleural effusion. Depth of breathing. The amount of air patient is exchanging depends on the rate and tidal volume. Tidal volume is the amount of air in millimeters that is moved in or out of the lungs during one breath. So that's assessment of the respiratory system. When we're assessing the cardiovascular system, we will check for abnormalities in the patient thoracic region. So we always start externally. Are there any signs of abnormalities? Pay particular attention to the rate, quality, and rhythm of the pulse. Check and compare distal pulses. Pulse rate is 60 to 100 beats per minute for a normal adult. The younger the patient, the faster the pulse. Tachycardia is greater than 100 beats per minute, and there are various types of tachycardia, which we will get more into when we start to do cardiology. And bradycardia is less than 60 beats per minute. The pulse can be strong, it can be bounding, it can be weak or thready. For the pulse rhythm, rapid when interval between each ventricular contraction of the heart is short. Irregular if the heart periodically has an early or late beat, or if a pulse beat is missed. And if you can feel a pulse that is irregular, then your patient has an abnormal heart rhythm. Blood pressure. Blood pressure is the pressure of circulating blood against the walls of the arteries. Decrease in blood pressure may indicate loss of blood or its fluid components. Loss of vascular tone or sufficient arterial contraction. Cardiac pumping problem, overdose on beta blocker or antihypertensive medication. So when a patient has a dip or drop in the blood pressure, it can be because too much blood was lost or too much plasma was lost. It can be because the blood vessels are too dilated or too constricted. It can be because the heart has been damaged directly, or it can be because the patient is on some type of medication that is blocking the stimulation of receptors in the heart, which causes the heart rate to drop, resulting in a low blood pressure. Systolic pressure is increased pressure caused along the artery with each contraction of the ventricles. Diastolic pressure is a residual pressure that remains in the arteries during the relaxation phase of the heart cycle. Blood pressure is reported as a fraction in the form of systolic pressure over diastolic pressure, measured using a blood pressure cuff with gauge, that's a sphygmomanometer. Most EMS agencies carry 4 sizes of blood pressure cuff: obese or thigh cuff, adult, pediatric, and infant. Hypertension is a blood pressure that is lower than the normal range. Hypertension is a blood pressure that is higher than the normal range. Now, the neurologic system assessment. Neurologic assessment should be performed on patients with changes in their mental status. You will consider the level of consciousness, their orientation to person, place, time, and event. You will use the AVPU scale to determine the patient's mental status. Ensure that you Inspect the head for trauma and assess for any gross neurologic deficits. Check the pupils. Pupils are normally round and equal in size. When a bright light is introduced, the pupils constrict, and if the right pupil constrict, the left pupil must constrict at the same time. With less light, the pupils become more dilated. Pupil size is regulated by a series of continuous motor commands that the brain automatically sends. Bilateral dilated pupils, bilateral dilated pupils that do not respond to light are usually due to death. And the AEMTs use the acronym PERLA, right? PERLA is useful guide in assessing the pupils. Pupils equal, round, reactive to light, accommodation. Anatomic region. And with the anatomic region, we're talking about head, neck, and cervical spine. Inspect for abnormalities. Gently palpate scalp and skull for pain, deformity, tenderness, crepitation, and bleeding. Check face for rash and petechia, which is spots of discoloration around the body. That's what petechia is. So you need to look for that. Assess the eyes. Check the color of the sclera. Check for foreign objects or blood in the eye. Check for bruising or discoloration around the eyes and behind the ears. Check ears and nose for fluid. Odors suggest the need to check the blood glucose level. Check neck for swelling or bleeding. Palpate for signs of trauma. For the chest, inspect, visualize, and palpate over the chest area for injuries or signs of trauma. And you're using a decap BTLS at this point, right? You're using your decap BTLS. Intercostal retractions, we're looking for that. This would indicate impaired flow of air into and out of the lungs. Paradoxical motion or asymmetrical motion is associated with a fractured rib. Auscultate for breath sounds. Must check for breath sound. All right. Abdomen. Look for trauma and distension. Palpate the abdomen for tenderness, rigidity, and patient guarding. Bruising over the flank area suggests blood collecting in the retroperitoneal space. Abdomen asymmetry may suggest a swollen organ. Severe distension may be caused by fluid in the peritoneal space. Assess for the presence of rebound tenderness. For the pelvis, inspect the pelvis for symmetry, instability, pain, tenderness, crepitus, bleeding, deformity, and any obvious signs of injury. Inspection of the pelvic area is not often done in patients with medical emergencies. In female patients, determine whether bleeding is coming from the vaginal opening, urethra, external genitalia, or rectum. In male patients, determine whether bleeding is coming from the urethra or rectum. For the extremities, inspect each extremity for decap BTLS. Check for pulses, motor function, and sensory function. Palpate each extremity individually. Posterior body, inspect the back for decap BTLS, symmetry, bleeding, and open wounds. Ensure you keep the spine in line at all times. Carefully palpate the spine from neck to the pelvis. Additional physical exams. If time permits, you may perform a focus assessment of each body system. Ask 2 questions. What additional problems can be identified through the exam? How will these findings change my treatment choices? And the final phase of your patient assessment is your reassessment. Performed at regular intervals during the assessment process. The purpose is to identify and treat changes in a patient's condition, reassess your ABCDEs, combine repetition of primary survey, reassessment of vital signs, and breath sounds. A repetition of the secondary assessment and a repetition of the secondary assessment. Compare baseline vital signs obtained during the primary survey and subsequent vital signs. So generally you want at least 3 sets of vital signs to be able to identify trends, whether your patient is trending up or trending down. Reassess mental status and ABCs. Reassess the chief complaint. So reassess the patient's chief complaint in light of treatments provided. Is the current treatment improving the patient's condition? Has an already identified problem gotten better? Has an already identified problem gotten worse? What is the nature of any newly identified problems? Recheck interventions. Reevaluate everything that has been done to this point. Management of the ABCs is most important. Ensure management of bleeding. Identify and treat changes in the patient's condition. If condition improves, continue the same treatment. If condition deteriorates, modify treatment as appropriate. Reassess the patient. Reassess unstable patients every 5 minutes. Reassess stable patients every 15 minutes. And that would be the end of this chapter.